Thank you again for our panel. We are going to go into our second panel in a second, but before we do, I wanted to play a video message from Greg Allman from the Allman Brothers Band. I'm sure many of you in this room have grown up listening to their music, as have I, and were inspired by Greg Allman talking about his hepatitis C status. And this is a video where he is engaged in an awareness campaign.
I didn't have any energy at all. I had lethargy real bad, and after about a week and a half of it, I figured something was wrong. My doc told me that I could have Hep C, and he did a blood test, and it was positive. I'm not going to fool you. It was rough. It was very rough. But sometimes you got to bite the bullet to get through hard times. So one of my big passions in the world, my biggest one is, of course, playing music and writing it, and recording it. And playing it live, that's probably the pinnacle. Where I wanted to help others and help others. And that's what I'm doing now. That's what I'll keep doing, probably for the rest of my life. What do you do of a morning when you get up and go out? You should go spread the word with me and make it your passion also.
Thank you. I think that that's actually a perfect segue into our community panel as well as panel with providers. And I'd like to invite Lauren Sand from Hepatitis C Caring Ambassador Program, as well as our panel members to come up to the stage.
Thank you, Greg. And I don't know about the rest of you, but I'm still dancing from last night, and I'm having a really hard time not, shake it and sugary. It was pretty amazing concert last night. There were 4 transplant patients up on the stage rocking, and I mean rocking for 4 hours. And some of us are a little exhausted from rocking with them, but it was an amazing night, and we're really looking forward to having musicians talking more and lending their voice to hepatitis. So before we get started, I just want to recognize a lot of people in this room. And Jules, before you walk out, I do want to recognize you. I know you need to leave, but thank you for all your work, Jules. Phenomenal. And there's other advocates in the room that need to be recognized, and I may miss a few of you, so if I do, please stand up. But Denny, Sue, Andy, Terry, Jeff, Karina, Joan, come on, stand up, guys. Let's get recognized. You guys are working your butts off. Sherry, come on. Joan, Sherry, get up. You guys are Martha, get up. Chris Taylor, Colin, Alan, Michael Carden, Brian Edlin. Come on, guys. Bill McCall, get up. We don't do this alone. We don't do this alone. We do this as a team. Brian, you walked in just in time. We do this as a team, and we all work together. This is not a one-man show. Daniel, you didn't stand up there. And I'd also like to recognize some of the advocates that couldn't be with us today, but are doing the work locally, as Seiji so correctly pointed out, that it's important that We act locally, and Ronnie Marks couldn't be here today because she's at City Hall in New York and working on making sure New York City is paying attention to this virus. And Ken Akanaka is in Hawaii, making sure Hawaii is taking care of this virus. And there's many other advocates around the room that are working really hard in their states, acting locally, who couldn't be here today. But just want to make sure we recognize everyone and know that we really think about all of you. And also there's many advocates who will never be with us. And Pam Kelly from Canada just died a few days ago. She was supposed to, be celebrating World Hepatitis Day with Pam, and she's not here. And there's many of those. And we need to have more action. And we need to remember those people. And I'd like to just take a moment of silence to remember everyone who's passed. I know they're all here with us today. So, to start with today, we have a fabulous panel up here, and I'm going to ask them a series of questions. And then at the end, we're going to have a very lively conversation, so I really want all of you to participate. We're going to start with Dr. Sanjeev Arora. He is the director of the ECHO project, which stands for Extension for Community Healthcare Outcomes. He's a professor of medicine in the Internal Medicine Department at the University of New Mexico Health Sciences. So, Dr. Sanjeev, I'd like you to sort of explain to us what is the ECHO project, how does it work, what are the results you've achieved so far, and how can this project be utilized on a national scale to improve care for hepatitis C? As you heard from HRSA, they're looking to you to do it, so how can we do that?
Well, I want to thank you, Lauren and Michael Lindbergh, for the invitation, and it's a great honor to be here. So I'm a hepatologist, just like Jake and another one you heard from earlier. And I was treating hepatitis C at the University of New Mexico. That's my specialty. In 2004, and there was an 8-month wait to see me. There were patients all over New Mexico. Less than 5% had been treated, and I knew I couldn't treat them all, because if one patient had to sometimes drive 250 miles each way and would have to do that 18 times during a treatment of genotype 1 infection, and as you know, this is a poor person's disease, and they had no way of doing that. So I asked myself this question: what is the way I can do what I later called force multiplication? That's a term that I've coined to describe a logarithmic improvement in capacity of care. That means 10 times more capacity to deliver care for something really complicated like hepatitis C. It was this question, I was asking this question because I was really troubled by the fact that people were coming to see me with liver cancers and end-stage liver disease. And this trouble in my mind created this model, which I call the ECHO model. And ECHO stands for Extension for Community Healthcare Outcomes, and it's based on 4 key ideas. The first idea is that we'll use technology to leverage scarce resources that may exist only at a university. As some of you know, to treat hepatitis C, it's not just enough to have a hepatologist. You need a psychiatrist. Sometimes you need a pharmacist. And so we had the team at the University of New Mexico, and the question was, how could we force multiply it? So we came up with the idea, and we said we'll use technology to leverage it and multiply it. Second key idea in the ECHO model is best practice protocols. We said there is one good way of doing this, one really great way of doing it. Let's everybody on the network, primary care clinicians, do the same thing. The third key idea is case-based learning. And we said doctors who are primary care clinicians in the rural area, out of 3,000, not a single one was treating hepatitis C. And I said, if they had to treat hepatitis C, how could we teach them? And the idea was straightforward. I said, let's teach them the same way that residents and fellows in our medical school learn, through case-based learning, as they co-manage patients with their professors. And I said we'd use technology for that. And lastly, I said we'd use the internet to track outcomes. So the heart of Project ECHO is something which we call a knowledge network. And every Wednesday afternoon, and I invite any of you to join us by video conference if you want to see one, about 20 clinicians, primary care clinicians from all over New Mexico join us on an interactive video conference. And one by one, they present patients of hepatitis C to our expert team at the University of New Mexico. And we help them manage these patients, and we also give them short didactic presentations which last 10 or 15 minutes every week. And over the course of a year, we've shown that they get tremendous improvement in self-efficacy. They find this is hugely beneficial. We give them continuing medical education credits for participating. And over the last 7 years or so, we've shown that we've set up 21 centers of excellence for treating hepatitis C all over New Mexico who join us every week in this knowledge network. And the way they learn is called a learning loop, that they learn from us, they learn from the didactic presentations, they learn from each other, but mostly they learn by doing. After hepatitis C was successful, we've now done this for 17 other disease categories. But in hepatitis C, the principal results have been that these doctors find dramatic improvements in professional satisfaction. We have provided more than 10,000 hours of CME credit. They find that their professional isolation is reduced. They find this is hugely beneficial to them. And lastly, we reported in the New England Journal of Medicine on June 9th that we did a prospective control trial which showed that the care that these rural clinicians, primary care clinicians provide is as good as that we provide in the University of New Mexico. And the last part of your question was, we believe that in order to really tackle the problem of hepatitis C nationwide, you need a triangle-based partnership. And that triangle should consist on one side of federally qualified health centers and primary care clinicians. The other side should be CDC and the Department of Health, et cetera, in a particular state. And the third part of this triangle should be an academic medical center where some of the hepatologists, et cetera, reside. And if you connect these three into knowledge networks, then you can create centers of excellence at the community health centers, which Seiji Hayashi leads, so essentially instead of having 2 or 3 sites of treatment in a state, you have 30 or 40 sites where patients can go, but they not only get the treatment there, they get the screening, they get the surveillance, they get their families screened. Essentially, you are integrating the prevention arm of your healthcare system with the therapeutic arm of your healthcare system and the primary care arm of your healthcare system for change for this particular disease. Thank you.
Thank you very much. And thank you for keeping that short and concise. We have time for questions and answers. I'm sure lots of people are going to ask you questions about that. Next up, we have Dr. Sue Wong. Dr. Wong is the Assistant Director of Medical Affairs at the Charles B. Wang Community Health Center in New York. CBW, as it is known, is a federally qualified healthcare center which serves the Asian population in the greater New York City area. Dr. Wong directs the center's hepatitis B activities, including a comprehensive care program for the infected community-based research hepatitis B moms and community screening efforts. So I think Dr. Aurora sort of framed it up for you. How do you see the role of community health centers filling the nation's gap of screening, care, and treatment for those with viral hepatitis? And how do you see FQHCs lending themselves to integrating hepatitis services into primary care?
Thank you. Thanks for having me here today. I wanted to just represent community health centers and where we might fit in the gap of care and treatment for many of those people who have viral hepatitis. So community health centers actually are the nation's largest primary care network. We serve more than 19 million people, and there are at least 8,000 clinical locations in every state and U.S. territory, serving unreached areas and areas that don't have good access to medical care. So it's especially important because viral hepatitis does affect many vulnerable populations that don't have access to good care. And I would say even with the Affordable Care Act, these patients are going to remain uninsured. Many will remain uninsured, And even those who are insured may not have good access to specialized care, as Dr. Aurora mentioned. So CHCs will continue to be and serve as the safety net provider for many of these individuals. So for hepatitis B, because we do affect the immigrant population, this is especially important because many CHCs are well equipped to offer in-language services and very culturally appropriate care. APJO, who's here, alone represents 25 different health centers that serve the Asian population. So, and especially because Hep B, half of those with Hep B in the U.S. are Asian. This is particularly kind of as somebody mentioned before, a game changer in terms of really relieving the burden of Hep B in the U.S. So and what we're finding at our health center is that many of our patients, this is critical in language services, and they tell us that they'll fly to New York from North Dakota because they can't find good service there. And they don't feel like their English is good enough to really be able to interact with the doctor, enough to understand their disease process and to actually engage in their care. So, and what this means is this actually impacts outcomes, especially in terms of diseases where you're talking, a year, at least a year of treatment. You need the patient to be really engaged. And recently we had a patient who knew she had hepatitis B for 20 years and had not seen a doctor during this time because she lived somewhere where she didn't have access to a in-language health center, and she didn't have insurance. There was a free clinic, but she said she just didn't feel comfortable going there. And unfortunately, by the time she came to us, she was already cirrhotic. She actually came in with jaundice and ascites. Her belly was very swollen, and the doctor immediately sent her to the emergency room. And I'm not exaggerating, we found out the next day she actually died because of a very severe esophageal bleed from cirrhosis. And it's cases like this that make us realize 20 years ago, if she had just gotten checked and been monitored, we would have been able to prevent this really unfortunate end. So, and then the other thing I feel like is really important for hepatitis B is that we provide services and support for these patients who often really feel stigmatized with this disease. And a lot of them, our patients are coming from China, where they were really discriminated and they weren't allowed to pursue certain careers, such as being a teacher or a doctor. And so a lot of them are really afraid to get tested and get treatment. And they're even afraid to talk to their doctors about getting tested. And so we basically try to encourage them, and tell them that it doesn't matter how you got it, and usually you get it from your mom, and we try to reinforce that there should be no reason for stigma, and we're finding that makes a difference. And I wish I could tell them, hey, you're in the U.S. now, there's no such thing as stigma and discrimination, but it's not the case, and we're recently actually finding out a number of cases of med students who are having their acceptances revoked from med school because they're found to be Hep B positive. And so this is not a done issue, especially in the U.S. So this is, one thing that we really feel like is important is to really create a culture where people are comfortable to talk about the disease and also encourage their family members to get tested. A lot of people are afraid to tell their family members because of this personal stigma, and as physicians, we also feel like we're advocates for that. So, and Seiji also mentioned the primary care medical home, and I feel like FQHCs are really poised to provide comprehensive care because we often have social workers, behavioral health specialists, which private physicians may not have, and we're able to provide really good comprehensive care. And when you're talking about Hep B and Hep C, where people are on long-term treatment, it's really important to have those services, which unfortunately are not reimbursed by insurance at this point. But because health centers do receive some additional funding from HRSA, we're able to provide kind of comprehensive care. We know several health centers, such as William F. Ryan in New York City, that are able to provide really good medication adherence nurses, and they're also able to provide really good substance abuse treatment, so that even if you are somebody who has a history of substance abuse, you're not automatically excluded from treatment.
Great, thank you. So next I'm going to call on Dan Church. Dan is an epidemiologist and the adult viral hepatitis coordinator for the state of Massachusetts Department of Health, where he has worked for over 12 years. He's a member of the committee that authored the Institute of Medicine report, Viral Hepatitis and Liver Cancer, a National Strategy for Prevention and Control of Hepatitis C. And before I ask Dan his question, I do want to acknowledge Dan and all the other viral hepatitis coordinators out there who are doing a fantastic job with no money. So Dan, can you talk about the recent epidemiological outbreaks that have been happening in young injection drug users in Massachusetts? I know John talked a little bit about it, but can you give us a little better understanding on what's going on there? And what do you see as the role of health departments in addressing the viral hepatitis epidemic?
Okay, well, thank you very much, Lauren, and also thank you for the acknowledgement about the work that viral hepatitis coordinators are doing and have been doing. And I also really want to thank myself, the organizers of this event, particularly Dr. Ko, for their leadership in making this finally happen. I think it's really exciting to see this happening after all this time. And I'm really happy and honored that I can be here to talk about the state health department perspective. In regards to your question about the young injection drug users, in Massachusetts, starting in around 2007, we started seeing an increase of hepatitis C cases being reported in young people. And when we started looking at our data more closely, we learned that a lot of this appeared to be due to injection drug use, and particularly injection of heroin. And at this point, where we are is we're getting over 1,000 cases of hepatitis C reported to us in people between the ages of 15 and 25 every year. And these are just the people who are in care, who are getting diagnosed and reported to us. So we don't even know what's happening at this point with the people who are not in care. And so this is very alarming because from Dr. Fenton's presentation earlier, the belief was that nationally hepatitis C transmission was declining. And that is very much not the case in Massachusetts. And it is also not the case in many other jurisdictions, as we're slowly learning. Although we really don't know the extent to which this is a national problem at this point, because surveillance for hepatitis B and C is greatly underfunded in this country. And so most states do not have a system that would be able to detect this kind of trend if it was even happening in their jurisdiction. So we really need to learn a lot more about what is happening, as well as making sure that there are prevention programs in place. In regards to your other question, Lauren, I think there are really significant roles for public health departments, and the Institute of Medicine report talks about the crucial role that health departments play in addressing these epidemics, and the HHS action plan also talks about that. And in Massachusetts, where we've had healthcare reform for a number of years, we've had some experience in seeing what the role is in a post-healthcare reform environment. And one of the areas that I think is really important is around services. And we know, and this was already just talked about, that we need to have prevention, education, and screening programs in place for people who are not engaged in care or are not eligible for care, so that we can help people get identified, get prevention education, and get into care if they're already infected. And then for people who are already infected, we need to have care coordination in place, and health departments have a very significant role with that. And in Massachusetts, we've actually been funding a limited number of integrated medical management programs that are serving people who are mono-infected with hepatitis C. And a lot of providers are not able or willing to treat people with hepatitis C because the treatment is so complex, and it's getting more complex. And so unless health departments can collaborate with the community health centers in their jurisdictions to help provide some of that care coordination, a lot of treatment can't happen. And when they do that, as we have in Massachusetts, we can see that a great many more people are able to be treated than would otherwise be possible. So another role for state health departments and local health departments is around education. And it's already been discussed that many providers, and I include social service providers as well as medical providers in that, do not have the information they need to take care of the populations they're working with. And a lot of bad information gets out there, a lot of non-information gets out there. So we really need to do a better job at making sure that these providers have the education they need to do that. And the final area is around disease surveillance, which is sort of where we started in terms of talking about this increase of hepatitis C in young people in our state and other states. And we wouldn't have been able to detect this change if we did not have a robust surveillance system, which we're very fortunate to have. And as I said, most states do not have a really good program for disease surveillance for hepatitis B and C. And without that, you can't know what's going on with these outbreaks in drug users. You can't know what's happening in terms of healthcare-acquired hepatitis infections. And you really don't have a good sense of what the overall picture of the epidemic is and where you need services and what those services should look like. So it's really crucial, and the IOM report actually recommends that every jurisdiction get funded to have core surveillance for hepatitis B and C. And I would really
further that. I think that's really important, and it seemed that was agreed by in the previous panel, which I was happy to hear. But I think it also needs to be extended that all of the services that I've just been talking about really are needed in every jurisdiction throughout the country.
Thank you. Thank you very much. So next we're going to hear from some patients. And before we hear from the patients on the panel, there's a few people in the audience that I do want to point out. And first off, Thelma, you didn't stand up when I was pointing out advocate. You did? Okay, well, thank you. Just, Thelma, thank you for all your work. Elijah, can you stand up? Good job, Elijah. Pam? And Gene Stein, a special friend of mine, liver transplant survivor, and a very special man. Thank you. Thanks for being here, Gene. So we're going to hear from John Moon. And Mr. Moon recently lost his brother to liver cancer, stemming from chronic hepatitis B infection. He's become an advocate to raise awareness about the importance of educating at-risk populations as well as medical professionals about a disease, as his brother's death could have been prevented. As a chronic hepatitis B carrier himself, Mr. Moon wants to promote education and research to improve the lives of others. So, John, can you tell us briefly your story and why you feel a person, or what do you feel a person with chronic hepatitis B needs to know, and what messages do you think healthcare providers could have delivered that would have saved your brother's life?
All right, so thank you for having me here, and thank you to everyone who are working on our behalf to fight this disease. It's really appreciated. So my story is actually not, it sounds like it's not too dissimilar to the unfortunate tragedy that can happen. And about a year ago, during Labor Day, we get a call from my older brother who was having some stomach problems for the prior 3 months. And we thought it was an ulcer or whatever, but he finally called and said that he went to see the doctor, and he was diagnosed with stage 4 liver cancer. And it was obviously devastating to us. And from the point of diagnosis to the next 6 months was the most excruciating period of my and my family's life, especially for my parents, who were immigrants who came to the United States to improve the lives of us, the children. It was especially devastating to them, and then just seeing the physical deterioration and the pain that my brother went through, and just the incredibly difficult conversations with him during that period. So we lost him 6 months from the point of diagnosis, and in finding out about his condition, I myself wanted to make sure about my own status, and so I was tested and found that I also had chronic Hep B. And so that sort of began a course of me looking into the disease and trying to understand it. And in looking at what doctors might have, or what may have been what we might have been able to do to prevent this, there are 2 points of intervention, I think, that were lost. The first was my brother lived in Seattle, an area that has a high concentration of AAPIs, and so from the family standpoint, and as an AAPI, I didn't know that I was an at-risk population, particularly coming from an immigrant community, and so had I known, and my mother, who was a nurse, knew that we may be hepatitis B positive, but didn't know enough to say that it's important to get tested and to be screened for it on a regular basis. And so that was a clear missed opportunity. Another missed opportunity was the physicians. My brother, when he turned 40, had multiple physicals, as is suggested for someone who turns that age. And in those physicals, at those different times when he had blood tests, again, it was a missed opportunity to see that he was an at-risk population, or doctors who know that he's at an at-risk population to at least suggest he should be screened for hepatitis B. So those were 2 points, and as I found out more about the disease, it was really frustrating because this is something that could have been totally avoided and something that would allow my brother to be here this very day. So what is the message that I've learned throughout as a chronic Hep B carrier? Well, first is that you need to be screened. And the other message is that at the different intervention points, it's not enough to say that it's important to be screened to know if you have hepatitis B. I think it has to be fairly impolite and say you are at risk of death. Because in my mother's case, she was a nurse and she knew it was dangerous, but she didn't know exactly how it was dangerous or exactly what she should do. There has to be an element of fear or of provocation or something. It sort of reminds me of the AIDS campaign, where silence equals death. It has to be something that's so alarming that it causes you to really think, I'm at risk, I should go and get myself checked, because the consequences can be very severe and very dire. So, what do I do with my life? I'm actually now a subject of several studies at NIH in the liver disease area, because I know that having data is very valuable in trying to understand this disease. I try to live as healthy of a lifestyle, I exercise, but most importantly, I've now taken on as a cause and a mission for myself to just, actually very probably inappropriately tell people that are at risk, at-risk population that, you should get yourself checked out. Because if someone had told me inappropriately that you should be checked out, that might have saved my brother, and certainly is keeps me from hopefully not having the same consequences as my brother. So that's it. Thank you.
Reminds us all of why we do what we do, doesn't it? So next up is Gloria Searson. When Gloria Searson was diagnosed with HIV in 1991, she chose to remain optimistic and fight the fight. She knew the odds of mortality. And during her request to obtain more information about her deadly virus, she learned more than even her providers knew. She set out to empower herself and others. 5 years later, she learned she had hepatitis C. Her goal has been to encourage everyone to be an advocate for their own health care. Today, she founded COPE, Coalition on Positive Health Empowerment, a membership organization dedicated to empowering people with HIV and hepatitis C to be better informed and to be able to make the necessary care and treatment choices. So Gloria, what are the barriers in the African American community to accessing testing, care, and treatment? And what do you think the community's role is to address these barriers?
Thank you, Lauren, and thank the audience for sticking around. I was glad you didn't save me for last. All the good stuff would have been gone. I really want to thank today's speakers because they really addressed what I consider the myriad of problems and barriers that we all have no matter what race we are. So I really want that to be said. I want to really tip my hat to Congressman God, his name just went on, Johnson, for talking and addressing stigma and to really put that out there, because I believe in the African American community is a huge barrier, as in most communities, but specifically because organized religion plays a huge role. And from what I know from my prevention partners, once you say you have something, it doesn't end there. The rest of the questions begin, and no one wants to answer the rest of the questions. So that's a barrier to even disclose or to ask to be tested, because then they want to know why. So, we have within our own community barriers that are there to support us, but yet they judge us and stigmatize us, and that is not fair, nor is it worthy of anyone. I think the other thing that we need to address is funding, Because although we have funding in HIV, there is no funding in hepatitis C. The majority of the people that I deal with and the people that I work with are people who generally are co-infected, if not with hepatitis C and HIV. It's with something else. As we know, the African American community is plagued not just by HIV or hepatitis C, but a host of other illnesses. And hepatitis becomes a special interest group of people that is up against other issues that are plaguing the African American community, like housing, like drug use. I mean, you can go on and on and on. And then where do we fall with substance abuse? And there's when the stigma surfaces, and we push that back to the burner because we think other things are important. So as we've seen from the government agencies forming an alliance and combining, I believe that that is a necessary tool for us in the community. We need to work together no matter which area of interest and expertise we believe in, because I believe if you're a housing organization, you believe treatment and prevention begins with housing. If you're a prevention organization, you believe condom and reproductive health is important. Well, the key is that I've been talking about this since 1993, and my own community didn't begin to listen until 1997 because they wanted to talk prevention. And I said, why can't treatment be a form of prevention? But they were afraid, they didn't trust it. So here lies what I believe is another barrier. We need to accelerate research. We need to prove that these drugs can work and cure blacks. If we do that, we can then have a different conversation with black people. You know, and we also have to be clear and be honest and tell the truth. You know, there's fear and mistrust. So why should I believe any of this is going to work for me? Nothing else has. So we begin by saying, we're going to do a study. Here's what really happened in Tuskegee. We're not going to deprive you of the drug. We believe it works, and we think if you do it correctly, you can be cured. A different conversation removes the barriers. Very different than we don't know. Yes, 17% cure. How many were black? Well, small percent. You know, these are the kinds of answers we give people. We play craps. I think the odds now look a lot better. I'd put my money on the pass line now with 76% than I would have with 17%. So we're getting there, and for that, I'm truly grateful. As far as the strategy plan, again, I heard and see and read a lot of great things. I love all the things that you guys wrote and have in your agenda. My ask to you is to let's see it, let's feel it, let's get it rolled out, no matter how small and incremental, but not let's have another meeting before we start. Because we've had the meeting, we already know it's a problem, let's get it moving, let's start today. And I think then we'll see some changes in the African American community, because we'll also see the changes around the other communities. And we tend to be, I'm from New York, I grew up in Brooklyn, and I need to say that because sometimes people think I'm from Harlem because I do a lot of work in Harlem, but I'm from Brooklyn. And one of the things that I know about people from Brooklyn is that we think just because something comes to New York, it doesn't necessarily come to Brooklyn. So just because these treatments came out, you got to remember that there are a lot of people in my community that don't think they're going to get to them anytime soon. So those are the kinds of things, if we see the government taking action as a unified body, then I think we could follow suit, because when you go back to where most of our funding comes from, it's from government agencies who I think have a great opportunity to interject intervention, technical assistance in the areas in which we're not ready for, to move some of our prevention organizations into treatment-focused organizations and try to use treatment as a form of prevention, reduce the spread of HIV and hepatitis C, and let's get some folks treated and cured. We just need a lot of money, a lot of issues, and a lot of training, a lot of education, and let's not forget to just continue to test and not miss these opportunities, which there are many. Thank you.
Thank you, Gloria. So last but not least, and I do want to remind everybody, I want you to line up and start asking these guys some great questions. We have Mr. Michael Nimberg. Michael Nimberg is the Executive Director of the Hepatitis Education Project in Seattle, Washington. It's a nonprofit organization. HEP provides support, education, advocacy, and direct services for people affected by hepatitis, particularly marginalized populations and those with poor access to health care. Mr. Nimberg serves on the executive board of the World Hepatitis Alliance. We saw a fabulous video from them earlier, representing North and South America. A former hepatitis C patient himself, Mr. Nimberg was treated and cured in 2009. So, Michael, what populations do we need to prioritize, and how do you think we can effectively reach these communities? And if you could only get one message out to the world about hepatitis B and hepatitis C, what would that message be?
How much time do I have?
3 minutes. No.
Well, with respect to prioritizing populations, I'm tempted to say providers. There's such a lack of information among the provider community, particularly primary care providers. We heard wonderful examples of innovative approaches from Dr. Arora and Dr. Wong today, with up to 75% of hepatitis patients undiagnosed and unaware of their status. I think that's a real priority population. For those who do have hepatitis, of course, baby boomers, we heard, make up 2/3 of the hepatitis C positive Americans, and we will hopefully have updated recommendations from CDC later spring next year, maybe a little bit earlier, that will include that age-based cohort, one-time antibody screening for anyone born between 1945 and 1965. Injection drug users, current and former, of course, former a more difficult population to reach, but we heard the sobering statistics from Dan Church in Massachusetts, and the rise in incidence among young injection drug users. Absolutely a priority population. Thrilled that the action plan includes a chapter dedicated to preventing viral hepatitis among drug users, and that is a real first, I think, from a national perspective with respect to viral hepatitis prevention. African Americans, both hepatitis C and hepatitis B would be a priority population. And I think if we really want to get rid of hepatitis C in the U.S., we have to address correctional institutions. By some estimates, up to 1/3 of Americans with hepatitis C pass through the correctional system every year, and policymakers, the community, doesn't equate public health and correctional health, but they are equal. 95% of those in correctional institutions will be returning to the community, so that is a huge reservoir, and it's really a missed opportunity when we're not screening and at least assessing the liver disease of those in prisons and jails. One message, that's simple: test, test, test. I think that we have to get people tested and diagnosed if we're going to make a real dent in these epidemics. Targeting the populations, of course, that would be most at risk: Asian Americans and API for hepatitis B. Native Americans are often left out of the conversation, but there is increasing evidence that there's a much higher risk of hepatitis C in Native American populations around the country. We've seen some great work in parts of the country, Alaska particularly, in getting hepatitis B prevalence dropped by introducing those birth doses and vaccinations for newborns and children. And I would say, going back to a priority population, I do think it's unconscionable that by CDC estimates, 1,000 newborns are born every year with hepatitis B. That is something that we really need to address. I can speak personally. My wife has hepatitis B. She's from China, likely contracted hepatitis B at birth, and we have a beautiful 3-year-old boy whose life was spared the potential fate of early liver cancer by getting that birth dose of hepatitis B vaccine, hepatitis B immune globulin, completed the series, and at about a year, he did get his titers checked, and he is immune. So test. Hepatitis C is curable. It's very simple. Test, treat. Not everyone needs treatment right away. There are very exciting drugs in the pipeline. We had the first 2 new drugs to treat hepatitis C approved by the FDA in 10 years this past May. Hepatitis B is treatable, and it's easily preventable. I'll leave it at that.
Thank you. Thank you very much. It's a good hand for our panelists. So Michael made a great point, and that is that we have some really effective new treatments, and we have a lot of new advances in diagnostics, and there's many people in the audience who are here from industry, and we could not do this without you. I would like to recognize you. Would you please stand up? Vertex, Gilead, OraSure, Merck. Come on, let's stand up. Let's recognize you for your advances. Everyone, yeah. We couldn't do it without your help and without your partnership, and it does take a team. So I'm going to start with Mr. Terry Baker. The reason the veterans are getting care and treatment is because of this gentleman in the corner over there. He's very shy about that, but you know, the VA knows who Mr. Baker is and has responded to him in a very positive way, and he's helped to change the lives of millions of veterans. And so, Terry?
Thank you, Lauren. First of all, I think it's a great day that, you know, President Obama made this World Hepatitis Day. And we have a action plan here now for the prevention and treatment of hepatitis, viral hepatitis. But mine's more of a statement. Viral hepatitis is not a magical rabbit we just pulled out of a hat. It's been around for a long time. I actually did, I will say, battle with the Department of Veterans Affairs and the CDC since 1999 to get treatment for veterans. I had the chance of getting here early and looking at this book. And goal 1.1, actions to be initiated during 2011, and I won't read what the actions are, but there's 2 of them. That's one of 28 actions of 2011. I don't know if anybody out there has seen any of these actions taking place, but if they haven't, we're now in August. I say to the panel, I say to every advocate, beware smoking guns. And I mean no disrespect to anyone sitting here, but the Department of Veterans Affairs and the CDC gave me smoking gun after smoking gun after smoking gun until finally something was done. And the only way something was done is by the advocates and pharma and everybody else staying and holding them to the fire. And I don't care if you hold them to the fire till they're on fire. You have to keep them on right there at the fire. Because the problem is even though they're honorable men and honorable women, they're run by a bureaucracy. The Department of Veterans Affairs was a bureaucracy. The CDC is a bureaucracy. And bureaucracy has a tendency to change what the thoughts and good ideas of certain people are. So I say to you, I know almost every one of you there. I know a whole lot of you out here. Hold them to the fire. Don't just take a piece of paper and a booklet. It's only worth the paper it's written on. Hold them to the fire. Thank you.
So should we bring back Greg Allman for Tied to the Whipping Post? Karina Dan?
Yeah, thank you. So I heard a few folks talking about work at the state level. I am also working at the state level in Maryland, and I know, for example, Michael Nimberg's doing some great work in the state of Washington with Dave Kern and Ann Brenner. And I wondered if a couple of the panelists could talk about some of the first initial steps and the key things that you're doing with states as advocates or as states with advocates. Just a couple, 1 or 2.
Dan, you want to start that? And Michael, maybe chime in?
Sure. Yeah. No, I think I mean, every state is very different in terms of how they're trying to address this and what kind of information they have available to them to start addressing this. So I can speak for Massachusetts that we are obviously what I talked about first here around the transmission of hepatitis C among young injection drug users. That is something that is of great importance to us, and we're really trying to explore not only how to do better surveillance for that so we can better understand what is actually happening and what the whole pattern of drug use is that exposes people to hepatitis C, but also to try to really think about what are the prevention programs that we can enhance and expand to try to meet this need. In Massachusetts, we have integrated a lot of our services into existing public health infrastructure, including HIV services, substance abuse treatment, and correctional health services. But with our HIV prevention programs, we've done a lot of work about trying to get hepatitis C and hepatitis B prevention messages out there. And what we're doing may be making a difference, but it's not making enough of a difference. And we would be seeing very different surveillance data if we were making a good impact with that, or enough of an impact, and we're not. So I think we really need to explore innovative ways of doing prevention, and I think that's one of the key things. And I also agree that provider education is going to be critical because we have these great new treatments. You know, hepatitis B is completely preventable, but they don't mean anything unless we can get people into care. And so we really need to enhance what we're doing with screening and services for people who are living with these infections.
Great. So I'm going to ask everyone to keep their answers really brief because we're getting almost the whole audience up here to ask you a question, which is fabulous. And we are going to run over a few minutes, which the White House has graciously allowed us to because they're enjoying this interactive talk right now. So Michael, do you want to add to that briefly, or should I move on to Doug?
I wanted to just say,
Okay.
I'm not working specifically with the state on hepatitis issues, but I am working with SASDAC, which is the state's AIDS Institute's strategy organization for HIV. And what I'm really trying to do is be the voice that continues to talk about hepatitis C, because even though there's no funding, I believe that some of the services can operate simultaneously. And I'm hoping that that grows further. And one of the things I am pushing them to do is to mandate their fundees or the recipients of their fundees to be trained in treatment and make that some sort of mandatory training for case managers so that they are more informed and able to advocate with patients around treatment.
And I'll just add one thing quickly. I think Dan hit it when he said we have to be innovative. I wouldn't say that we're in the years of lean following years of fat. I think we're in the years of leaner that followed years of lean. Federal government, state budgets, there's very little out there. What I would like to do is thank CDC and Dr. Fenton and Dr. Ward for making, for the first time, monies available in HIV prevention to be used for viral hepatitis prevention. And that's something that is happening in Washington State. We have a very proactive Department of Health in the state, and we are taking advantage of it. So I think doing more with less is going to be the name of the game for the short term at least.
Just want to add one quick thing that for a state program, something I just want to add is not to forget hepatitis B, because I feel like a lot of the state programs are very developed in Hep C. And I've talked to Colleen in New York about this. They have a lot of grants for Hep C, but nothing for Hep B, and I'm hoping that we can move forward to do more, to be more inclusive of both.
Great comment. Dr. Doug LeBrecq.
Yeah, first I'd want to warn John and Kevin and the others just to be certain they don't get Terry Baker on their bad side. That would not be smart. But I wanted to make two quick clinical vignettes to make 2 points. I'm unfortunately not in the baby boomers because I was born too early to be a baby boomer. So apparently I'm safe, I guess. But in the early 80s, I had a very young woman come to me, had a young child with hemophilia that had HIV. And she was in tears. She wanted to live long enough to take care of it. He was going to die. Everybody knew you'd die in early 1980 if you had HIV. Well, he was lucky. He got into experimental programs for treatment. He's still alive. She's dead. I guess I kept my promise because he was still alive. But, you know, she was gone in 10 years. And, you know, I'm thrilled with the progress and the research and the resources that have been provided for HIV, experimentation for HIV, research for HIV treatment, and we still need more. But I'm tired of trying to play catch-up with my hepatitis patients. I want to get the same treatment, the same resources for my hepatitis patients, so I don't lose people like this mother that never should have died. That's the first point. The second one that we barely touched on today, but is, in my mind, a crisis and an epidemic now, is hepatocellular carcinoma. Again, when I started at Iowa, if we saw 1 or 2 patients a year with HCC, it was a grand rounds case, because we never saw it, and it was usually hepatitis B. Now I see at least 3 cases a week. In 1 2-week period, I had 7 cases. 4 of them had been previously diagnosed with hepatitis C, but nothing had been done. 2 of them, they had actually been treated. 1 had failed treatment. The other one had cleared the virus, but they had cirrhosis. None of those 6 patients were being followed. The 7th one was a sub-Saharan African-American, been in the U.S. 20 years with severe hypertension on 4 drugs, very good internist taking care of him, back pain for a year. When they finally took an x-ray, he had a 17-centimeter tumor. And they thought it was in his kidney. They still hadn't thought about hepatitis. And when he came to surgery, nobody had yet checked him for hepatitis B. We have to get not to the hepatologist, not to the gastroenterologist, not to the transplant people. We've got to get to primary care physicians. They have to start screening for hepatitis, just like they make sure you get your tetanus shot, make sure you get your influenza shot, to make sure that you do the mammography, you get the colonography, they check the cholesterol. This has got to be on their tick list, because if they don't identify the patients, we're never going to treat them. We're never going to prevent them from progressing to HCC or failure from hepatitis B and C. We've somehow got to reach those people. And in terms of priorities, to me, a key priority is educating primary care at whatever level you want to call primary care, OBGYN, et cetera. We've got to get them to identify the patients so we can treat them.
Thank you. Thanks, Doug. Question over here?
Yeah, I'm Evelyn McKnight from Hepatitis Outbreaks National Organization for Reform, or Honor Reform. We've talked a lot about populations. We've talked about awareness and advocacy and education. I want to talk a little bit about a transfluence of those factors. I'm in a population that all of you are in a population of, and that's those people who access health care. That's how I contracted hepatitis C. During chemotherapy for stage 3 breast cancer, a nurse reused a syringe to access a large saline bag, and during port flushes, then 99 Nebraskans contracted hepatitis C in that way. It's not an isolated incident. In the past dozen years or so, there's been 40 such documented outbreaks like that, where reuse of syringes to access a multi-dose vial was the vector for transmitting hepatitis C, or HIV, or hepatitis B. So we're very pleased to see a chapter in this action plan that talks about healthcare-acquired infections, and we're delighted to see this getting some national attention. Maybe, Dan, you can talk a little bit as an epidemiologist about the other kinds of outbreaks you talked about through drug abusers, but if you can talk about what you see and what kinds of surveillance methods sort of start you thinking about maybe this is healthcare acquired infection through reuse of syringes or other unsafe injection practices.
Sure. Thank you very much for your comment. Yeah, healthcare acquired hepatitis is something that is of great concern both nationally and in Massachusetts, and we certainly have seen some examples of possible healthcare acquired infections that we've had to investigate as part of our surveillance procedures. And this is something that we're able to investigate because we have surveillance procedures. And we have a surveillance system that allows us to identify some of these cases, although, you know, again, viral hepatitis surveillance is dramatically underfunded, as are all viral hepatitis services in this country. And so our ability to really find these cases and follow them up is very much hampered by the lack of staffing that we have. The Department of Public Health in Massachusetts doesn't have any direct funding for surveillance. But we've been able to do this because we have a very automated system. And I think that making sure that all states have access to automated systems that will enable them to not only identify those cases, but other outbreaks and the epidemics in general is really what is going to be needed. Because if we don't have those in place, it's very hard to find these. And we really need them in every jurisdiction because, as you said, everyone is accessing health care, we hope, and increasingly so. So we really need to have good surveillance everywhere to make sure we can pick up on these cases as soon as possible so control measures can be put in place.
And also, there's lots of prevention that can be done. These are completely preventable situations.
Yeah.
Thank you.
Thank you very much. Jean?
Listen, thank you very much for having me here today, first off. My name's Gene Stein, and I've had hepatitis C, discovered that I had hepatitis C, I believe, in 1992. And I went between 1992 and I believe it was 2007. I went through 2 series of interferon first, and then interferon with ribavirin, and both were failures. And I proceeded to go into end-stage liver disease and had a transplant in 2007. And but I will tell you, I'm still hepatitis C positive, and I don't know really at this point if it's beginning to attack the new organ or not. I probably need to have a biopsy done here very soon to see what's really going on with that. But I'd like to address my question to Dr. Church. You mentioned that a lot of younger people that you were seeing were heroin users. Now, I know everything with this virus seems to point to blood, but has there ever been any consideration given to actually researching the drugs that these people are using? Because certainly these drugs are manufactured very crudely. There's no laboratory heroin or cocaine or meth. Has there ever been consideration given to that, to actually study the drugs that are known to be associated with hepatitis C?
Sure. Thank you very much for your question. Well, I think there are so many different research questions that we have because we've known that this is happening for several years, and really we have been able to do very little to address it at this point because there's so little funding, not only for surveillance, but then for the services for people who may be at risk. So how people are getting infected, we recently worked with CDC on an EpiAid to try to get some more information, and we did get some great information from that, but we certainly need quite a bit more to really understand what the transmission patterns are. We know from what we have in surveillance data, which is what we're able to get through these automated systems, that a lot of this does appear to be due to injection of heroin and other drugs. But obviously there are a lot of questions that remain in terms of really understanding not only what's happening there, but then what are the prevention programs we need in place to interrupt the chain of transmission.
Okay.
Thanks.
All right, thank you.
So we have just a couple more minutes, so I'm going to ask the last 4 questions to be really brief and the comments even briefer. So Jeff Caballero?
You know, I just wanted to give, first and foremost, really express my appreciation to the President and to the White House Office and the Office of National AIDS Policy for your leadership on this convening. But I also wanted to give a shout out to the Office of Minority Health. You know, several years ago, it was Dr. Graham's office that really stepped up and helped the Asian American community convened our expert panel on hepatitis B, which led to the Assistant Secretary's report, which facilitated the Institute of Medicine's report that helped us all get to this stage. So, without the Office of Minority Health support in these areas, I just wanted to acknowledge that. So again, thank you. I do have a question, and it's to Dr. Aurora. Clearly, the ECHO project is widely recognized, and you've spoken about, the hepatitis C activities. Since we have, CDC, HRSA, and we did have Ron. Oh, there, yeah, it's still here. What do we need? I might be on fire, but What do we need to do, or how close are you to having a B curriculum as well that we could use and replicate in our targeted areas around the country?
Sure. I think that we already have a B curriculum. It's just not a very major problem in New Mexico, and so we haven't implemented it yet. But I certainly agree with you that just like there is a shortage of resources for hepatitis C, there is a tremendous shortage of resources nationwide for hepatitis B. What the ECHO Project Knowledge Networks do is by bringing the primary care workforce and the academic center and the departments of health together, is that whatever task list needs to be done can be done at any point of contact that the patient makes. You don't need to refer the patient from one site to another. And so that will produce the efficiencies needed to enhance the workforce that we're talking about. We don't have only one hepatitis coordinator, and so we'd like to have 20, and that's what we are trying to do. And your point is absolutely valid. We do need one ECHO projects for hepatitis B in those states where large Asian American populations live, and we'd be happy to collaborate with you in some way. We are currently collaborating with HRSA and CDC to try and see how we could set up ECHO projects in different states. And the truth is, once you set up the infrastructure for an ECHO project, it's like laying a railway track. You can drive many trains on it. We have 19 ECHO projects going on in New Mexico for asthma and rheumatology, for HIV, and so on and so forth. And so I'm hopeful that once we set this, hepatitis B will come along very nicely.
We look forward to working with you on that.
We'd like to sign up as soon as you set that up in New York.
As I've said before, ECHO everywhere. Andy, and really, really brief, we need to wrap this up.
Actually, that was my question. So you answered it. Thank you. And I can't wait for it to come to Florida.
And Joan? Joan Block from the Hepatitis B Foundation.
I'll make this quick. So I just wanted to say one of the things that was missing today is I did want to say that San Francisco Hep B Free, we didn't talk about the community-based model of patient education and provider education. And I also wanted to recognize one of the corporate sponsors for the San Francisco Hep B Free, and hopefully for the Hep B Free Philadelphia is Subaru, and Abana Jacobs is here representing Subaru. I also did want to say, I want to introduce my husband. Everybody knows me as kind of the stand-up loud person. My husband, Timothy Block, is president of the Hepatitis B Foundation. He is actually here with me today. And then the final thing I wanted to say, I wanted to thank John Moon for sharing his story, because one of the big issues in the API community is that we're not really, one, we don't like to talk about our illnesses, and two, we don't want to talk about hepatitis B. So it takes a lot of courage. I'm really very glad that you did it, and that ultimately how we're going to make changes through all of us, the advocates and the patients and families, it's going to really come from the ground, and then having people like CDC, HRSA, HHS, they're going to help us, but really it's going to come from us. So thank you, John, Gloria, Michael, for sharing your stories.
Thank you.
Okay, I'm going to make this extremely
Martha,
brief.
one final comment?
Yeah, extremely brief. Lauren has stood up there and acknowledged everybody all day long. I need to acknowledge Lauren. She's finishing her 2-year stint as the chair of MVHR. Lauren and I together, hand in hand, have brought MVHR to a new era. I could never have done it without you. We definitely play good cop, bad cop an awful lot. So now that you're not going to be chair, I'm going to have to get mean.
Well, thank you, and thank you to all our panelists. Excellent presentations. Greg, you want to wrap this up? And thank you for all our audience hanging in there with us on this wonderful World Hepatitis Day. I can't tell you how thrilled I am that we have a World Hepatitis Day. There's so many years we went to HHS and no one was ever assigned to hepatitis. We now know, now we got Ron. He's on fire back there. He's tied to a whipping post and he's ready to go, and we're going to make him earn it. So thank you.
Great, so we're quickly coming to a close here. Before we end the day, I want to make sure that people do take the free copies of the Presidential Proclamation as well as the HHS Hepatitis Plan. We're all incredibly proud of these documents and many other documents that have been coming out of the federal government, and please be sure to go ahead and take them home and to share them with many members of your constituency and friends and family. Now I'd like to invite Jeffrey Crowley, the Director of the Office of National AIDS Policy, to the stage to offer a few closing remarks.
Hello, everybody. I'm going to be brief. I would like to thank Greg for moderating today's event and also for all his work in planning this. You know, we know that groups always get excited to come to the White House, but also this group was sort of an extra special case that he's been working with many people for a year, and there's a lot of excitement and enthusiasm, so we're really glad to have you here. You know, I'm not going to run through the list of federal partners, but it is exciting. I do want to just acknowledge all the people that are doing so much work at HHS, but CDC, SAMHSA, HRSA, all the federal agencies, so thank you for doing this. You know, I'm the director of the Office of National AIDS Policy. I'm senior advisor on disability policy, and it's interesting that, you know, as before this meeting started, someone was like, well, how did you get this issue? You know, and I think there's a lot of overlap with it. One of the realities of the White House and the Domestic Policy Council is, you know, there's a few of us and we cover lots of things, but there's certainly a lot of overlap between HIV and hepatitis, and even just hearing the discussion today, it really reinforced that. One of the key parts of our national AIDS strategy is really focusing on coordination. And it feels like that's a central strategy we need here with hepatitis, you know. And we're talking about coordination at all levels, across the federal agencies, federal, state, and local governments, with the community. And that really seems like something where hopefully we can continue to make progress together. You know, as I know with our AIDS strategy, it really is nice, whether you like every word in or not, it's really nice to have a plan and have a roadmap, just because it allows everybody to sort of focus on one direction. So it's really great to have this HHS action plan to look forward to. You know, just really briefly in closing, you all came in that way. You may not realize sort of where we are, but if you go out this door, you're really just across the driveway from the West Wing. And, you know, the president is over there, and, you know, he's been working day and night on this deficit ceiling deal. And these are really sort of fateful times for our country. And, you know, he's been saying, you know, we need a balanced approach. And, you know, getting this balance is really critical to our response to viral hepatitis and a lot of the priorities we care about. And we, you know, believe that it stands in real contrast to what the other side is putting out. But, you know, when I look at, you know, the president's time in office, they've always been challenging. You know, he will tell you that he ran for office and he got in office and his to-do list was fundamentally different. You know, he felt like he had to pull the country or the world back from the potential of a global depression. But, you know, one of the things he's also said is, despite the fact that he's been challenged in ending wars and working these bigger issues, he's also determined that his administration is going to do great things on some of these other issues, including viral hepatitis. And so I just want to thank you, because any success we will have won't be anything we've done alone. It's really in partnership. And so it's really great to see such an energized community come together. And so I hope that you go back home, and as several people have said, it's not just a plan and a document, but it really comes alive. So thank you very much.